Welcome.
Take a pause, practice the pause. Everything's going to work out.
Yes.
Okay, well, I'm here. If you need anything, just message me on the other messenger thingy or in the chat or whatever works for you.
Thank you. Much appreciated. I'm trying to get all my little forms and all my stuff together. You know what's kind of confusing sometimes though is the when just getting used to all when I'm in the other meeting, the board meeting, doing the quorum, I'm like counting, I'm writing down stuff and I'm trying to get it together. I'm like, shoot, who's who?
Yeah, I know. That one is kind of hard.
I'm gonna present this. And actually, we'll take this one. Someone just popped on. Good morning, Chelsea.
Hello.
Hello.
Oh, goodness. It has been a heck of a week, ladies. And I mean that because in the school year and all the fun stuff that goes with it.
We're getting close to the weekend. Hopefully that helps.
I know this weekend is full too. Can you guys see the slide okay so far, the first one?
Yeah, do you have the agenda? Maybe you want to have that as the starting slide.
Yes, I do have the agenda. And I actually picked that. Let me go all the way back here. I don't know why that one did that. Hold on 1 second. Thanks, Chelsea. I was looking at the slides and wanted to see if you guys could see it. I'm like, oh, okay. I guess I should go all the way back to the beginning instead of trying to go through them. I'm getting more confused.
It looks good.
Hello, Dania. Good morning. This is Patrick.
Good morning, Patrick.
So we'll get started here in just a few. And thank you for the email earlier this morning.
Absolutely.
Well, good morning, everyone. This is Patrick Jones tuning in from sunny Spokane, downtown sunny Spokane, and it's a couple minutes before the hour. We will get started at probably a couple of minutes after the hour and get ready for a very good program. So thanks for joining us, and we'll start very shortly. Well, again, welcome to the June meeting of the Greater Columbia ACH Leadership Council. This is Patrick Jones, the fearless facilitator out of downtown Spokane, wishing we could all be together, but knowing that this is actually good for many of us to meet given the widespread of our 9 counties. As you can see on the agenda that Demia has posted, we are going to be talking about largely community paramedicine and in conjunction with some community health worker programs. And I just wanted to preface our meeting today by saying that one of the overriding goals of the Medicaid Transformation Project is to engage in novel approaches to the delivery of healthcare. And I think it's fair to say that these approaches that you're going to hear about shortly are novel. And I hope you'll have questions of them to see whether they may apply to your communities or just if you have questions in general. So we will have time for that as always. Before we get started, I just wanted to point out that Sunday is Father's Day. And if we were together, I would probably go around and ask people what your thoughts might be to honor your father or somebody in your life who is father-like. But it is, I think, a unique American institution that we do this, just like we've done Mother's Day for so many decades. And I also can't help but brag a little bit that Father's Day actually started here in downtown Spokane in the 1920s after a good church lady thought that mothers were great to be celebrated, but fathers deserve that too. And as a result, she mounted a campaign to start a Sunday honoring fathers, turned out to be June. And so we are doing that today, decades later. So happy Father's Day to those fathers on the line. And I hope you will acknowledge in your own lives somebody who is a father or father-like as well. So before we start, we would like to have a land acknowledgement. And can you put that up on the screen, Demia? And I don't know whether there's anybody on the line who feels motivated enough to overcome any shyness you may have about talking to 60-odd Washingtonians about the land acknowledgement that we recite and sincerely and pay homage to the Yakima Nation. But I would entertain somebody raising his or her hand to see whether you would like to do that.
This is Norma with Coordinated Care Washington. I would be honored to do so.
Thank you, Norma. Go ahead.
We should take a moment to acknowledge the land on which Greater Columbia ACH residents live, work, and play. It is the historic homelands of the 14 confederated tribes and bands of the Yakima people. The Yakima people remain committed stewards of this land, cherishing it and protecting it as instructed by elders through generations. We are honored and grateful to be here today on their traditional lands. We give thanks to the legacy of the original people, their lives, and their descendants.
Thank you. I'm so glad we're doing this. We've started doing this over the last few meetings. So Demia, would you mind putting up the following slides? So as we typically do, we're going to start out with a staff report. And then as you saw, we're going to go start on the east side of the Columbia River in Pasco, bounce back to the west side of the Columbia River, checking in with Kennewick. And then we'll end the meeting by hearing from a community a little further east of the Columbia, but not too far, Walla Walla. So let's start with some synopses from the staff of the Greater Columbia ACH. And Carol, who's going to kick that off?
Well, let's see who wrote the first article. Demita?
You need to move the slides.
Demita, can you,
This is Demita Warren from Blue Mountain Counseling in Dayton, Washington.
Sorry, my computer froze. 1 second, please.
Good morning, Demita. So your name and Demia's name are very, very close. We were asking Demia to give us the report.
We'll both be answering. That's okay.
here we go. Okay, take it away, Carol.
Okay, so just to let everybody know that Greater Columbia ACH is busy getting ready for reopening. We are sending a policy forward to the board of directors today on a return to work safely policy. But in the interim, we have been remodeling our current office space so that everybody can have offices and work safely, and that those who are not vaccinated can work in their offices without having to don a mask. So our goal is to open at least 3 days a week by the end of the month, and have everybody in the office so that we can start collaborating and working together. So that we're having a potluck this Friday just to kind of, say hello and have people pick out their offices. But otherwise, at the end of the month, we will plan on opening with, hopefully, with some of the businesses in the rest of the state. Next. Sam, is that?
Yes, but we were going to do that last because it's opening into our presentations.
Okay.
Thank you, Carol.
It's still
okay, then this is me still. Put my camera on here. I'm trying to turn it on, but it's not starting here. Okay, there we go. So practice transformation program. So I'd like to send a big kudos to cohort 1 for increase in follow-ups. We are going to start highlighting all of our dashboards so that we get a better understanding of utilization, and also to be able to look at gaps and opportunities. In this particular one, in an effort to improve the efficiency of the healthcare delivery system, GCACH provides technical assistance, and it talks about these sites fall across 3 cohorts that differ in organization. So these particular diagrams are for cohort 1, primary care. There's a dental office. It does not include hospital. So we're looking at ED follow-up and inpatient follow-up. One of the requirements in the program, milestone 6 in the Greater Columbia CARES Model Toolkit, is to develop systematic coordination of care across the medical neighborhood. This milestone was designed to close the seam of care for patients as they transition between settings. In performance year 1, 2, and 3, providers were tasked with reaching out to willing partners and take a more systematic approach to working with hospitals, emergency departments, and specialists. The graph below includes the first quarter of each year as a comparison, excluding hospitals. Way to go, cohort 1, for the achievement at 81.8%. And Demi, I can't see the bottom graph. Thank you. So the first graph is the follow-up to 72 hours of hospital discharge. And you can see that we started out at 28.5% in that program year 1, quarter 1, 27%, program year 2, quarter 1. Of course, that was during the start of COVID. And then also 81.8%, way to go, cohort 1. And then the follow-up with a 1 week of ED discharge. And if you look at that, there is a significant increase in that. And I can tell you one of the examples of that is Providence, and looking at their rate of return on transitional care reimbursement for that particular milestone. So 79.3% at the first of this year. So way to go. Thanks.
Okay, anything more on that front, Sam?
No, we're just excited to be starting out with a new year for our cohort 2. So thank you.
Great. Okay, and you'll be able to show us some similar graphs, similar results in the next quarter or two?
Definitely. We're going to highlight different cohorts, different benchmarks, and really start just looking at each one of those and what they mean and how we can look at successes and opportunities. Thank you.
Great. Thank you so much. We'll catch you shortly. Okay, practice transformation. Laurel?
Yes, so I'm excited to bring this success story. Comprehensive Healthcare in Yakima and Yakima Neighborhood Health Services are partnering to provide primary care at the site at Comprehensive Healthcare. So already at the site in Yakima for Comprehensive Healthcare, they have a sampling of services that include substance use disorder and addiction treatment services, children's, youth, and family services, outpatient mental health treatment, Aspen victim advocacy, community education and outreach, suicide and self-harm prevention and treatment and support. But beginning on June 1st, Yakima Neighborhood Health Services began to be on site. And they had been previously, but due to COVID, we're not able, but have returned. And we're all very excited about that. It allows patients that are enrolled with comprehensive health care needing a primary care provider to have their physical health needs addressed. The Yakima Neighborhood Health Services nurse practitioner and medical assistant team are on site Monday through Thursday from 8 a.m. to 5 p.m. This partnership between Yakima Neighborhood Health Services and Comprehensive Health Care represents a significant commitment from both organizations to offer health care in a way that meets all overall healthcare needs of the patients they serve. And we are delighted to partner with the organizations. In a recent publication from Comprehensive Healthcare, Jody Daly, the president and CEO of Comprehensive Healthcare, said, by recognizing the importance of mental health to overall health and the integral role that behavioral health care plays in healthcare itself, we will continue to support the well-being of our local communities. So I obviously, we're all very excited about this and so pleased for the patients that get to take advantage of this service.
Very good. Thank you, Laura. And congratulations to both organizations in Yakima, and may that experience inform communities throughout the ACH. Okay, a community health program, Diane Halo.
So we are excited. Our community health worker program is starting on July 1st. We have contracted with 11 organizations, and we will be releasing those funds to those organizations as soon as we get their contract signed and the certificate of insurance back from them. So if you're one of those, then you still need to sign your contract, sign it so we can get the funds to you. And then, so we are having a supervisor training on June 22nd from 1 to 4. And this is going to be about, they're going to be covering, defining roles, responsibilities, navigating the work environment, building respect, safety, supervisor relationships, and connections over time. So I know that there's probably many other supervisors out there that are supervising community health workers. And if you are and you want to attend this, you're welcome to. If you would wanted to reach out to me, I can send you the meeting invite, but we're excited. Seth Doyle will be presenting this presentation for us. And so if you are interested and you would like to be part of it, just let me know. We're doing it by Zoom, so there's opportunity to have other organizations if you would like to be part of that.
Thank you, Diane. And I haven't checked the numbers, but my strong hunch is that with this program, we will double the number of community health workers in the 9 counties.
Hopefully,
Chelsea.
when we continue it.
Pardon me?
Hopefully we'll be able to continue it after this. So hopefully that it'll be a success, and then we can keep doing it.
Right. Diane, we might mention that we are planning to start a second cohort in January. So there was, I think, we had capacity for more community health workers. So we're hoping to launch a second cohort in January of 2022.
Yes.
Great.
Diane, this is Suzanne Swadner. Just a quick question.
Yes.
As you finish and you move people out into their practice settings and get them actively engaged in the internships, is there a way for us to kind of get a map of where this doubling of CHWs, has been deployed and how that's contributing to the overall plan for addressing population health? And by that, I'm just meaning, where are they at and how do they fit into the projects that you're doing?
Yeah, that's definitely one of the things that we can do. And we also, I just wanted to mention too, we will be providing training. So we're creating a community health worker cohort, basically. And so if organizations have community health workers that would like to be part of the trainings that we will be doing, please reach out to me and we can add you to those trainings. Because we're going to be doing mental health first aid at the end of August. And then in September, we're doing trauma-informed care and motivational interviewing. And then we will continue to have other trainings once a month. So it would definitely be, if anybody would like to have their community health workers part of that cohort, please reach out to me and we can definitely get them signed up for, I could add them to our list of community health worker to our community health worker cohort.
Very good, thank you, Diane. Any other quick questions of the community health worker program before we shove on? Okay, Chelsea, let's hear about the local ramp team.
Hello and good morning. Let me pull up my notes here. So last month we began sponsoring a community-based project related to the Lord of Life Mission Possible ramp team. They're a group who builds wheelchair ramps and other mobility access projects for clients within the Yakima Nation, Yakima, Benton, and Franklin counties. These projects allow vulnerable clients to safely and more readily access services in all 4 of our GCACH project areas. Without these ramps, stairs, and handrails, many clients are homebound, their mobility is restricted, and they have fallen, some injuring themselves when using existing stairs to enter or exit their homes. The picture you see here is from a recent ramp they built for a family in Pasco, Washington. So this home has 2 family members who are wheelchair bound, and we're super excited to see the result of more ramps to come throughout the rest of the year.
All right. Nice job, local ramp team. Nice job, ACH. And shoving on, what's next? I think we're going to circle back to Sam, but we want to hear on the social determinants of health, which is something that we've been working on for, my goodness, 2 or 3, 4 years now. So, Brisa, do you have a report for us so you can synopsize here from the newsletter? Brisa, are you on the line?
She is on there. It looks like she's not muted. Brisa.
I'll tell you what, in the interest of time then.
I'll do it. I'll do it. It's
I'll
fine.
have somebody else on staff just give that report.
Can you hear me?
We can hear you, Diane.
Okay. Brisa says for some reason, nobody can hear her. Anyways, so the local health improvement networks, the highlight that we're going to highlight this month is that Kittitas County Health Network, they are a nonprofit organization now. They're the LIN in Kittitas County, and they were awarded a federal level grant from the Health Resources and Services Administration KCHN strives and always achieves a mission to improve population health through the cross-sector collaborations. And let's see, the different areas in which the grant will be are childcare, substance use disorder treatment, and then also and to increase and sustain funding for mental health and substance use disorder. And then they're also expanding their community health worker program there as well. And so they're part of that program that we're doing.
Hello. Okay. Hi. Sorry. I don't know why I've been having issues with my audio. This is the second time in a different meeting. I had to jump off and get back on, but sorry about that. But yes, thank you, Diane, for stepping up. So yes, we decided that for every report out, we were going to highlight a LIN. Last month, we highlighted Benton Franklin Community Health Alliance. And for this month, I wanted to highlight Kittitas County Health Network. Like Diane mentioned, these are all of their highlights for a lot of their projects that they have going on, a lot of success stories. And yeah, we just want to thank them because they've really stepped up to the plate. They've really been active in their community and are constantly looking for different ways to fund different programs. I know with mental health, that's been one of their top priorities, as well as with the social determinants of health. They have really taken on the lead to look for more community health workers. I know at our last quarterly LIN meeting, Kittitas County had a lot of, like I said, all this information that we're looking at right now. They shared it at our last meeting. And I was really impressed with their community health worker expansion because I know they've also been doing a lot of work in their community where they have had also some promotoras. I don't know if we're aware with them, but the promotoras that they've had, I know have been working for doing their work voluntarily. So it's just really nice to see that they're going to be now getting paid for the work that they're doing. A lot of COVID outreach and a lot of mobility and getting people in the community to sign up for that vaccine. So yeah, that's a quick update on the Kittitas County Health Network.
Thank you, Breeza. I'm glad you could tune in.
Patrick, I noticed that Robin Reed, who's the executive director of KCHN, is on the line. So
I was just going to call on Robin because Robin, you said you had something you would be happy to add.
Hey everybody, nothing specific to add. I just wanted to let them know that I was here and if there's any questions. But yeah, we're doing a lot of really exciting work. We're getting ready to go from 6 staff people to 13 with just some of the new work we're doing around COVID outreach and care coordination. So a lot of exciting work going on.
Very good. Very good. Sometimes small counties can do mighty things. Okay, do we need to circle back to Sam to wrap up this, or we want to talk about a little bit of our financial snapshot? So, Heidi?
Yeah, so this one will be short. So last month we paid, so Sam mentioned or reported about the success of the cohorts, specifically cohort 1. So actually for the first quarter of 2021, our providers earned 99% of their possible project incentives. So last month, GCACH paid out almost $2 million to our contracted providers and for cohorts 1 and 2. So that's a huge achievement, and congratulations to our providers.
Okay, anything else, Heidi? You want to talk about cohort 3?
No, these are actually, the table below shows the amount of money that we paid to different cohorts.
Okay. Okay, so we see there about $2 million went out the door in Q1, right?
Mm-hmm. Yeah.
All right, and may the money be well spent. Okay, again, I'll just ask Sam, do you need to pop into with a little presentation again, or are you done?
No, we need Sam to do hers. So, yeah.
Sam?
Hear me? Can you hear me?
Yeah, we can hear you.
Okay, yes, no, I'm ready. This is just going to lead into all the other presentations. So it says, consider this for a moment. Community paramedics visiting diabetic patients to check vital signs and make referrals, or community health workers assigned to teams in medical homes and accountable care organizations to educate overweight patients on healthy eating and exercise habits. These may not be the roles of the paramedics or the CHWs have traditionally performed, but with our new incentives created by population-based payment methods, and providers are increasingly looking at ways that community-based practitioners can provide basic health care services to the patients, and that actually leads to cut cost. Growing evidence suggests that expanding these types of alternative staffing can help improve population health, reduce cost, and then goals such as reducing those emergency medical service calls. What we've learned from Kennewick Fire Department and Eric Nielsen, he will be talking about that as well, where he can attest to that, is having those community paramedicines and that transitional care and having those liaisons and advocates for the patient. A lot of times they don't know what's going on in the home, so it's been very beneficial. And I had the honor to be a part of that program with Eric. For the June Leadership Council, we have invited a variety of participants to speak to their paramedicine and community health worker programs, and we're hoping it will provide a valuable insight for the community paramedicines and the staffing roles that they play with that.
All right.
And thank you.
And
we could have the
one more note from you, Sam.
Excuse me?
Just one more, right?
Oh, yeah, we can do this one. Have you explored ways to improve communication? This is our learning collaborative that is actually coming up. So shared decision aids, and also looking at self-management support and how they intertwine with chronic disease management. My practice navigators will be reporting out and sharing success stories, just overviews, tools to use for this particular learning collaborative, as well as some of our sites will be representing and talking about how they've implemented processes, unique processes, I must say, within their organizations, and how valuable that's been.
Okay, so shared decision-making is the topic at the next learning collaborative, and that
shared decision-making and intertwining. We're calling it tools, valuable tools for the patient management, but definitely combining those two milestones of shared decision aids and then self-management support.
Great. And time and place?
It was at the top. It's always the Thursday. It's the Thursday, last Thursday. So it'll be next Thursday. Do you have it up?
The learning collaborative is on Friday, June 25th.
Okay, thank you.
From 2 to 4.
Next Thursday from 2 to 4.
Thank you.
You can access
Friday. Sorry, it's next Friday.
Oh, it's next Friday.
Yes.
Oh, did we move it to Friday? Sorry about that. I couldn't see the date on there.
Yeah, no,
it's in the chat too.
The fourth Friday of every month is the learning collaborative.
Very good. Okay, I think we've gone through our report. Carol, before we move on to our first presentation, do you have any concluding remarks about staff activity?
I do, Patrick. Somehow we kind of skipped over the article about Wes Lucky, who was our deputy director, resigned from his position in May, and we wish him well.
Okay. All right. Good luck, Wes. He's done a lot of good work for our organization, that's for sure. Okay, well then let's dive into our first presentation. This, as you can see on your agenda, it's from Pasco's Fire Department. We have two co-presenters, Ben Shearer and Michelle Crowley. And welcome Ben, welcome Michelle to the Greater Columbia ACH Leadership Council meeting. and we are all ears about what you have been doing and what you have learned and what you might pass on to others in the 9 counties about your falls program.
No, this is actually, isn't this Eric's?
Yeah, this is Eric's.
Yes, I'm moving back now. 1 second.
Okay. Sorry, Eric.
All right.
Oh, that's right. There we go. I know your program, Eric, a little bit.
Yeah, so he's going to go first.
Oh, okay. You confuse me.
Yes, and I don't know. It's all good. We'll just go with Eric. Sorry
Eric.
about that.
Can you hear me?
Can it a little louder, Eric? That would be better.
Can you hear me now?
That's better.
All right, I will project. Well, good morning, Leadership Council. Thank you for this opportunity. It's been a while since we've talked about this. In speaking with Diane and Sam, we talked about me just kind of doing an update to the previous presentation that I did a year or more ago on falls. Am I presenting or are you presenting? I'm not seeing anything on my screen at the moment.
Okay, I thought you said you wanted to present, but I can present.
If you'll let me. Okay, nope,
have it.
I got it. Nope, I got it right here. This is better.
Okay.
I'll do it this way. Can you
Okay.
can you see my screen now?
Yes.
Yeah, so this is an update from a presentation we did, if I remember correctly, back in well, I want to say early 2020, but I didn't think COVID was going on at the time, but it was somewhere back in that time frame when initially KFD was had started to deploy an idea with aging and long-term care of how we could identify people who are needing assistance in the home who were not under services, and where we could maybe get them connected with people. Since then, we've expanded it to where that data is free flowing out of our records management system, our EMS records management system with Richland Fire and Pasco Fire as well. I wish I could. I'm gonna kind of tell you the end story first, and then I'm gonna take you guys through it. I wish I could tell you that this is a smashing success and that all is right in the world, and that people who fall in the home today will never fall again tomorrow. That is not the end of this story. And it's also a story of what happens when, for a number of different reasons, whether it's a pandemic or it's changes within an organization such as a fire department, that you can't keep focused on an area and like so many other competing priorities that we might have in our day, something gives way. And so there's a little bit of that in here too. So I hope I'm not painting just a big doom and gloom picture, but I want to speak reality into this. Earlier this week, Michelle Crowley with Pasco Fire and Mike Van Beek with Richland Fire, we all had a conversation and about this information, and what we all came, I think, to agreement on is that it's a great concept, it's a good idea. It's not where we want it to be, and there's more to be done. So kind of jump into the end there, but hopefully with that, you'll kind of be able to see a little more realistically what it is that's happening here. So there we go. Okay, so let me give you just a quick 30,000 foot view here. Benton Franklin County EMS is largely delivered by fire-based EMS organizations providing the full range of 911 services. Kennewick, Pasco, and Richland Fire Departments respond to the vast majority of 911 calls in this portion of the Mid-Columbia, and approximately 80% of our 911 calls are EMS related. In 2020, KFD responded to a little over 10,000 calls, Pasco a little over 6,000 calls, and RFD over 7,000 calls. And again, those aren't just EMS, those are fire in EMS. So anticipate about 80% of those are EMS related. Now, we went back and we captured data through aging and long-term care. In 2020, 2,365 EMS events were, actually, this didn't come from aging and long-term care, this came from our own data here, were either for a 911 call that involved a fall, the primary impression of the paramedic or EMT was a fall. The secondary impression of the paramedic or EMT was a fall, or the cause of the injury included a fall, or the incident complaint included an assist. And we did that because so many of our assists, I mean, a very high percentage of our assists, like probably over 95%, are fall related. In 2020, the average age of all falls in between Benton, or excuse me, in Kennewick, Richland, and Pasco was 72. It was actually like 72.3. Just over 60% of them are female, which I think we tend to see. That's probably right in line with the demographics that at least it has every appearance that females tend to live a little bit longer than men. 88% are over the age of 50, and 80% of our falls are over the age of 60. And of all of those, only 44% were transported to the ER. So I'll explain more about that here in just a second. So in 2020, injury was the primary impression in 31% of the fall patients, which that's a good thing, you know, not as many as being hurt as it could be. And of the 741, 35% were the result of a ground level fall from furniture, toilets, showers, or the like. In 2020, 31% of fall patients required 3 or more personnel to safely lift them. And the average fall during that same time frame required 2.3 firefighters to safely lift the patient. What's interesting about that number right there, when we look at elder care facilities and things like that, many of which are staffed with only 1 or 2 people at night, our experience says that, at least from an average perspective, and I realize averages aren't necessarily a good statistic, I think Patrick would all tell us that, the staff that it may require, even in a licensed home, may be more than what is typically done in order to get people back to their pre-fall position. So 66% of fall patients over the age of 50 are not going to the ER. That's the flip side of that earlier statistic that said only about 44% of them needed to be transported. So what's wrong with that? Well, what's wrong with that is that who in the rest of the world knows that the fall occurred in the first place? And when these falls occur with someone who's living alone, whose loved ones weren't notified that 911 was called, or grandma or grandpa doesn't have a serious injury and don't need to go to the hospital, they're probably less than likely that they're going to tell anyone about it. So we also see that many of these fall patients are to what we refer to as MVPs, our multi-visit patients. So we're not just going on these falls one time, we're going on them multiples of times. And I'll talk more about that in a second. And at the end of the day, what we end up with is people developing a false sense of security because they've fallen multiple times and maybe haven't been injured yet. When what we know is that obviously there is a high percentage of deaths that occur in this country every day from falls, and if it's not the first one, it's still not that it's not going to happen. It just hasn't happened yet. So our idea that we had, and we still believe that it's a good idea, even though it needs to be worked on some more, is that we've got this 2-ton elephant in the room, and that 2-ton elephant is falls, all right? But we have problems fully seeing and connecting the dots of how to deal with the falls. So the idea that came to us some time ago is that what if we could just ensure that we could connect the most appropriate services with these people who are having the falls, who have the staffing or the logistical ability to put all that together. Not every department has the ability to put resources in place, such as like the Pasco Fire Department has put some great resources in place as of late. Not every agency could do that. So what if there was a way that an agency who doesn't have that capacity could do something? And that's what we were trying to accomplish here. So, and I'll talk about exactly what that looks like here in 2 seconds, but the idea was to connect all these dots so that we can see the problem more clearly. And maybe the person who ultimately connects the dots and puts it all together doesn't have the solution, but they're getting people involved who do. So the idea here originally was that Kennewick Fire, and we tried this, and it was successful, to take our fall data, or all those cases in which there were falls related, and feed that data to aging and long-term care, where then their caseworkers could follow up. So let me back up, not that far. Pre-pandemic, the Kennewick Fire Department had a community paramedic on staff, and that community paramedic worked hand in hand with Maricela and some of their caseworkers over at Aging and Long-Term Care, so that when we had falls, our community paramedic was being notified of those falls, Aging and Long-Term Care was being notified of those falls, and within 24 to 72 hours of the referral, Aging and Long-Term Care was assigning a caseworker, and efforts were being made to contact the individuals. We'll talk about what some of our liabilities, well, not liabilities, but what some of our difficulties were in that in a second. But the key thing that was able to happen was that pre-pandemic, we had the community paramedic who could dedicate the time to making sure that we had good data and we were making those connections. And then on the flip side of that, Aging and Long-Term Care had the ability to go out and do in-home visits and assessments. Obviously, when the pandemic hit, that changed a lot of that. After about a year of good success and seeing people getting enrolled into services, we started also feeding that data out of the Pasco Fire Department and the Richland Fire Department. And so with that, we have the following data. So to date, between the three of us, we've referred 2,317 people to Aging and Long-Term Care for falls and services. And of those that we referred, just over 1,400 of them qualified. And obviously one of the first qualifications is that they aren't in a licensed care facility. Number two, that they're at least 60 years of age, and then that they're not already under services in which those services are already at maximum capacity. Because what we did find in some of these is that they actually already are under services, but maybe they needed more services or more hours. Of those 1,400, just over 50% were reached. So the little, these are just my little squiggly marks here. The arrows going in both directions are indicating that that is virtually the same number that we had in the first year of this program, where just KFD was putting the information out there. Then we had 137 of them agree to falls assessment. That is a drop of about 5% from what we were seeing pre-pandemic. And then after that, we had a drop of it dropped again from about 15% who had agreed to services previously to about 9%. So that, why is that? Is that they're afraid to have people come into their home for services because of the pandemic? Is it because we weren't able to connect information with them and have our community paramedic talk with them more? There was a number of times pre-pandemic in which people would be resistant to services, and we'd see that in a number of ways. They either would not pick up the phone when Aging and Long-Term called, or they would not return a survey or information that was mailed to them. And whenever we saw that resistance, we engaged our community paramedic. And one of the beauties of a community paramedic is they walk in some form of a uniform that identifies them as with the fire department. And there's almost this immediate level of trust that's inherent. And that's not always true with a caseworker, and that's nothing against the caseworkers, obviously. That's just kind of how it is. And so, we're not really sure why we saw that drop. I think the two reasons I just gave you seem logical, but we would have to do a lot more legwork to figure out exactly why that is. So But what we do know is from all of these, from referrals that we've done, when aging and long-term care first engaged in this project with us, they had 2 case managers, and they increased it to 4 for the referrals that they were receiving from KFD, RFD, and PFD. So, so what are the services? Oh, let me back up. So of those, and again, it's only 69. That's, you know, I wish I could, you know, tell you that it was 1,000 people who had engaged in services. 69 of them did agree to start services, which are 69 people who had not previously been enrolled in any services. So you know, that's not nothing. But as Michelle said to me the other day, she's like, that doesn't sound like a success. And I wholeheartedly agree with her. That does not sound like a success. And it does sound like something that we need to put more energy and effort into it. And just like I started off my conversation, we can't take our eye off the ball. We have to stay focused on these programs. These are not just turn them on and let them go and they work. We have to continue to invest in them. So what are the services that were delivered in the home? So these are the different services that aging and long-term care enrolls them with: family caregiver support program, the tailored support for older adults, the Medicaid alternative care, and then long-term services and support. And then the hours that they receive can range from 20 to 200 per month. And of course, that is based on the assessment that is done by the caseworker and what they qualify for. So where do we go from here? Well, as I've already kind of indicated, we need to do more. We need to continue to focus on the referrals. We do have an issue within the fire departments on referrals. And one of those big ones is making sure that we are collecting accurate information, meaning we are getting accurate phone numbers, making sure that we're putting down the correct addresses, because obviously when you make a referral that often is being filled out at potentially 2 o'clock in the morning when you're still rubbing sleep out of your eyes, and you're helping this person make sure they're not injured, you're getting them back into their pre-fall position, provided that they aren't injured. And then you're taking in data, and we have mishaps with data. So we've got to continue to make sure that our referrals are as accurate as possible so that the caseworker can make that contact. And then we need to engage those who are resistant to services. Let's be clear. A lot of these result from people who are living in an independent type living, and they want to keep it that way. I have an 86 and an 84-year-old. My parents are 86 and 84 years old. They live alone, and they want to keep it that way. And I've lost count of the number of in-home care providers that my mother has fired because they don't have the, we'll call it the nursing bedside manner that she had when she was a nurse for 40 years. And so there's some pretty high expectations there. So we have to engage those who are resistant to services or who fire their service providers, I would say, and encourage them to keep what they have and not dismiss it, and to trust, right? I mean, because a lot of this also comes down to trust, because these are people who are coming into their homes. And then we need to fortify the process and ensure the contact information is accurate. I already kind of touched on that, but not again. And this is where we need to continually cycle back with ALTC, get data, where are our strengths, where are our weaknesses, and see how we can improve. So one of the things I didn't touch a lot on in this is that at the start of 2021, KFD lost its community paramedic. We will get the community paramedic position back in the spring of 2022, but we are feeling that void. There's it was unfortunate that it happened. It was no there's no blame or anything on anyone. It's just some unfortunate circumstances occurred that put us in that position. We have to have positions within the fire services if we're going to be able to help expand and connect the other ancillary services out there with these people in the home who are underserved, not served, or are managing to fly underneath the radar but yet need that help. So we really appreciate the Leadership Council, the ACH, for all the work that they're doing and trying to connect fire and emergency services in these different ways. I think you guys are going to hear some great things here in a little bit from Pasco and all the work that they're doing. And then from Walla Walla, I know everybody is trying to do their part in making these connections and serve the public better. And we need these partnerships such as with the ACH to make that happen. And that's all I have. Thanks for your time. And I'm open to any questions if you have them.
Well, Eric, thank you so much. That was not quite, I wouldn't preface that by that's all. It seems like that's a lot. And you certainly have provided us with a candid explanation, candid accounting of what you've gone through over the last couple of years. And I really appreciate that candor, because that's how we learn. That's how everybody learns. So before we shove on to the next presentation, let's take some time and see if some of you have questions for the Kennewick Fire Department, in particular, Eric. It seems to me there were definitely some steps along the way that you may have thought about and maybe scribbled something down. So now's your chance.
Eric, this is Suzanne Swadner from the Healthcare Authority. This is a really great presentation. I've been talking with a colleague in my agency who's starting to do some following of this in her role, kind of monitoring EMS, and it's so great. I'm going to pass along to her. I wanted to ask you, because I am thinking about the connections that are possible to increase penetration and the engagement in the community. Have you worked with the Home Care Workers Association that manages the folks who are out in the individual homes with some of these more complex patients and getting Medicaid level home care?
A little bit, and it's been kind of on a case-by-case basis, and that was possible when we had our community paramedic. But right. I would not say that it hasn't been, and I don't want to use the word globally, but I guess I will use it. But the only reason why I'm using it is that any fall that we have documented is going to ALTC. So I wouldn't say at that level. It's been more on a case-by-case basis.
So you have a way to connect it through that. And I'm just thinking of that because I'm working with them a lot right now on workforce issues and this question of kind of scope and what the home care workers can support in making connections to navigate care and navigate needs for clients. And I'm glad that the ALTC folks are getting this. And if you wanted to go any further, I'm sure the ALTC folks there could help, but I could also help connect you to the folks who manage that relationship with the union that addresses and manages these home care workers to see if maybe there could be some training that might be possible in your area to increase the knowledge and awareness of the services that you offer.
That would be great. Maybe we can connect offline.
Super, we'll do that.
Okay, thank you, Suzanne. So we have a question from Norma about whether there's any consideration by your folks, Eric, to offer things that improve balance. So preventive activities such as Tai Chi.
So again, when we had our community paramedic and we would identify those things, we were able to do some of that work. Ben Shear, who's going to be talking next, he's done a phenomenal amount of work in that area. He can talk more about that. But I will say that when we did come across those issues, yes, and Knights of Columbus was a big part of that because they have so many different tools, or not tools, equipment and things, wheelchairs and grab bars and things like that that could be obtained quite inexpensively, and then worked to get those things in place. But again, this is what happens when you lose a position such as we did, and we were not able to continue that as we had previously.
Okay, fair enough.
So Patrick, I just wanted, oh, go ahead.
No, go ahead. I think, Estaquio from the Yakima Community Foundation. What's up?
Hi, thank you, Patrick and Eric. Thank you for a great presentation. I just wanted to chime in to tell you that You know, hearing you present 69 people does not seem like a failure to me at all. And, you know, especially with elder parents, you know, I know how scary it is and how much I worry about their safety. So thank you for doing this important work. And I think it's a really good way that we can leverage really what we're all trying to do here. And I'm interested to see what we might be able to do to help supplement some of those efforts, because it's a tremendous asset to be able to go into someone's home, you know, as a fire or first responder, and have the trust and faith, and that maybe the kind of resources that you could point them to could be, might stick better than if we just knock on a random door. So I would be interested to ask you, what do you think might help you be more successful?
Well, for us, it's going to be able to having the bandwidth to do that work, right? I mean, that's what it comes down to. And I'm hopeful for 2022 when we're able to get that bandwidth back. That's what it takes, is having the ability to put a person in that position, or persons in that position, because there's clearly plenty of work to be done, and to help engage them, reassure them, follow up with them. In one case, and I didn't bring it up, we had an individual that we had been to 10 times for falls, all non-injury. And when aging and long-term care finally got to him, he said, yeah, that happened once or twice, but I'm good. And they were able to show him the 10 referrals, of which he acquiesced and said, okay, you're right, it's been 10 times. And he then engaged with services. So we have to be able to have the manpower to engage with that. So that to me is the big step one that any organization is going to have in order to keep this connection going.
All right. Thank you, Eric. We've got, I'll take a couple more questions and we need to stay on tune. So here we have a question from Peggy, and let me bring this up again, Peggy. Do you get involved with anybody from Department of Health on their programs with falls? This is a question for Eric.
Well, I'm not sure which programs you're referring to. The Department of Health does have a falls coalition, and I know Ben and I have both attended those meetings, and some others from local areas, as well as I've attended some of the ones at the state level. So we're in contact with them, but specific programs, no, we have not with the Kennewick Fire Department.
So maybe Eric, you and Peggy offline, or you could just have a private chat here just about what might be available that could assist not just Kennewick, but the other fire districts in the Tri-Cities.
Yes.
Or elsewhere. And Carol, just to wrap up then, Eric's slot here on our meeting, you had a comment or question?
I do. I just wanted to tether this all back to the presentation that Chelsea talked about, the ramp team at Lord of Life that applied for sponsorship funds through Greater Columbia. This is the reason that Greater Columbia was able to sponsor such a great program, is really in preventing falls. And there are many, many stories that we hear about people not having good access to get into their homes or out of their homes. And if you saw some of the pictures that I have seen about the inadequacy of stairs going into the home or out of the home, you would really appreciate the work that we are really proud of the Lord of Ramp team doing, and was really happy that Chelsea shared the picture of the ramp that went into the city of Pasco. So I hope that Ben and Michelle appreciate the investments. And just to let the Leadership Council know that we do have these sponsorships available, and we've expanded them beyond just events to be able to incorporate these types of programs. The maximum amount is $5,000, but if you have somebody that's out there that can do these kinds of works or teach Tai Chi, for example, to a group of individuals that are having falls, we would be very interested in looking at your grant, your grant application.
Yeah, and then I also wanted, this is Diane, I also wanted to mention that, you know, Greater Columbia Accountable Community of Health is wanting to do hopefully in the future, do a community paramedicine cohort. So that would be something that Sam and I have been working with Eric and trying to figure out how that we could do that for the 9 counties. And so just keep that in mind, that we are working behind the scenes and trying to figure out a way to do that. I don't know if Sam wanted to bring up anything about that.
I don't. We're just in the infancy stages of looking at that and assessing the communities and building a survey that would have, you know, and definitely we'll get some, send that out so we can get some more input on what questions that we need to ask our community and what their needs are.
Mm-hmm. I would be curious to learn, you know, how much would it take to have a person dedicated to this? You know, Eric, have you had an opportunity to budget what one resource would look like, especially if we can get them, you know, trained?
Well, I think there's a number of different ways that it could be handled. A lot of that's going to come from a level above my pay grade. And because you're dealing with fire departments, it also engages unions. And so I would not want to, I certainly have in my head the what the cost would be if you went one way versus you went another, and there's a pretty big gap between those. But a lot of that is going to end up being, you know, what is that particular union within the fire department open to? How does the agency want to tackle it? And then you're going to, only then will you be able to really have a best idea of what it's going to cost. I will tell you that if it's going to be a union firefighter paramedic serving in the role as a community paramedic, that is going to be the more expensive route. But it's also potentially, and I'm not saying this is the only way it could be done, gets you some buy-in right out the gate because of the uniform. So just some initial thoughts.
Okay, well, thank you, Eric. Give you a round of applause for that presentation. I hope you all got something out of that you can take home, take back to your work, and I know Eric will be available for further questions and offline conversations. In the interest of staying on track, let's turn to Pasco now and hear from both Michelle and Ben about their use of paramedicine via community health workers. And I don't know how long this has been going on, but we will shortly find out. So Michelle and Ben, the floor is yours.
Hi, thank you for inviting the City of Pasco Fire Department to present at the Leadership Council. We're really excited about sharing our Pasco Navigator program. First, I want to introduce myself again. I'm Michelle Crowley. I'm the EMS captain for the fire department. Ben Shearer, he's our community risk reduction. He's not going to be presenting with me today. He's on a needed vacation in Idaho. So today I am going to introduce you to Chief Dunbar. He's going to help me along the way on these slides.
All right. If you wouldn't mind getting a little closer to the mic, Michelle, just so we can hear you a little bit better.
Okay. I'll try to speak louder as well.
There you go.
So I'm going to jump right into going pretty quick through these slides. This presentation took me about an hour last time, so I'm going to try to be as quick as I can. I'm going to jump straight into the history. In 2014, the City of Pasco started collaborating with Consistent Care. They had a contract at the time with Lourdes with their readmissions. We found out that we had a lot of patients in common that were high utilizers of the 911 system, as well as using the ER. At that time, we were able to sometimes submit maybe one person a month and identify them as well as through Lourdes. And we would be able to figure out why they were calling 911 so much. Consistent Care would send a patient advocate, and we would meet at the patient's home and try to establish pre-hospital care plans and or try to find out what's the reason why they're calling 911. Is it an education or is it a need that they need? So sometimes we didn't have much involved into it because it wasn't our program, but we kind of latched on, as well as Kennewick and Richland as well. We would go to their monthly consistent care meetings and discuss patients. And so that's initially how we got involved with the community health worker aspect. In 2018, we started a hotspotters program, and those were patients that we identified that the fire department was visiting, the police department knew these patients, the court systems, the ERs, and so we were able to establish that along with partnership with Consistent Care to identify that. Moving on, the city of Pasco has always had a Pasco municipal code to charge for non-transports. Sometimes that was a way for us to be able to defer people from calling 911 inappropriately because they didn't want a $250 charge. Also in 2017, the city of Pasco had developed a municipal code regarding 911 abuse. Fortunately, we have not had to use that since then, but one of the reasons why that came into place is because of an extreme high utilizer of the 911 system. But that is available. I don't know if the other cities have anything like that within their municipal code, but it is kind of a backup that we have. In 2019, both Ben share the risk reduction with the fire department, and then myself, we started collaborating together and trying to figure out how we could reduce 911 high utilizers of the system. We both have our own jobs that we're trying to do within the department, and so we kind of were scratching our heads trying to figure out how are we going to help? How can we reduce the calls and help the residents that live within our community? Next slide, please. We came up with the idea of, we didn't want a paramedic community program because we didn't want to be going out doing well checks and checking vitals. We really figured out quickly that this is all about resourcing or navigating all the resources that are out there. There's a large bubble of, agencies that say they can do a lot of things, but how do we connect the dots? And so we really determined that we needed to find a community health worker that could help us help our patients that are calling. So we brought the idea to our fire chief. Our fire chief brought it to our city council and our city manager, where it was approved that we could hire a community health worker through Consistent Care. And we did fund that through our ambulance utility tax. We established the name of our program, which is exactly what we wanted the community health worker to do, is to navigate resources. And so Ben and I came up with Pasco Resource Navigator, and that's the PRN that you're seeing up top. Our goals are just as it says on here: reduce the high utilizers of 911 by connecting our patients to current resources available in our community. We're really trying to stabilize and help them find resources to one, have a healthier life. One of the things that keeps coming up over and over again, with all of our agencies, is that they just keep calling 911. We're very, very good, the fire department, at stabilizing pre-hospital care emergencies. We're very good at driving our fire engines and putting the fires out. We're very good. We're in the homes of people. We see what they're living in. Going back to Eric's presentation, falls is a really big heavy hitter with us. A lot of times we go to many, many patients falling, and they are using the 911 system to get help. Next slide, please. Going back to the staffing. So 2019, we decided, the city approved us 20 hours a week through Consistent Care. We did hire somebody. She was flexing, and we figured out very, very quickly that 20 hours a week is not enough time with the amount of patients that we were getting referred. In 2021, we extended it to a full-time position. It's a new program, so it's growing very, very rapidly. We're very proud of all the work that our resource navigator has done. Some of it's thinking outside of the box. A lot of times the fire department doesn't think outside the box when it comes to patient resources and their needs. So it was very advantageous for us to join up with Consistent Care and use a community health worker because they already are navigating the system. Their experience is valuable. I mean, we as a fire department don't understand housing or how to house people. There's a lot of training with that, and so the partnership has been extremely beneficial for our city and for our fire department. So right now we do have a community health worker. She works full-time. There was since it was a new program, there was a lot of figuring out in the beginning. So there was a hiring process that happened. It was a collaboration between Consistent Care and the fire department. Consistent Care was in charge of hiring this person through their I don't know how to explain that. They hired them, but we also were part of the interviews. We were really asking for someone, we wanted bilingual because, you know, our residents, that is a constant issue with us going out to 911 and having like a barrier, language barrier, so that was very important to us. And we really wanted an experienced patient advocate. Next slide. So the initial training started with Consistent Care. They did most of the training. Once that training was established, then the community health worker came to Pasco Fire Department. There's things that we figured out that we needed to incorporate as a partnership because the community health worker is not a firefighter. There was a lot of things that we figured out that we needed to do for training. So the community health worker joins us in the morning on our shift briefing. She joins us for our monthly staff reports and gives reports on her patients that she's working with that have been referred. Radio use was a big thing. We figured out very quick. We go into houses always with partners, and we always have a fire truck that's our backup with 2 personnel. And safety became a very, very big concern because they're working solo, they're going out in the field. And so we established pretty quick that we needed them calling out on the radio so that way we could do tracking and make sure that the community health worker is safe. There was a lot of training with civilian trying to understand how a fire department works and the hierarchy of ranks and just in general how we respond to our city. That was a lot of training went into that. We provide our community health worker with Pasco Fire uniform, and we provide a city vehicle. Next slide. These are some of the other things that we have established. We provided a laptop, again, the vehicle, a radio with a call number. Any PPE that is needed during the pandemic, you know, our community health worker was going out in the field when other agencies weren't, and so we provided that worker with the same PPE that we would wear in N95s and additional PPE that they need to protect themselves. Business cards, we figured out pretty quick that we needed to have first name only, just because of some of the patients that we do go out to, of course. There's behavioral elements and or substance abuse, and so we really wanted to make sure that, you know, there was nothing like they weren't tracking this person off duty, or identifying their personal car was a big thing too. We also have a partnership with our union, our local 1433. We do have an outreach committee. A lot of times we are housing people that might only come with a basket of items. They have helped us donate basic needs like soap, toothpaste, socks, underwear, blankets. And so, like I said, it's a huge collaboration amongst our own agency, Consistent Care, and the rest of the agencies that are helping us out. Next slide, please. Here's the criteria. So as you can see, number 2, falls risk. I mean, that really is a heavy hitter. And going back to Eric's slide, a lot of times it's not just a fall. We walk into their homes and we do identify, oh, okay, There's a lot of self-neglect or just neglect in general. The house might be a hoarding home. There might be some mental aspects or alcohol, drug abuse. And sometimes it's not just as simple as the person is weak and they fell, but there's a lot of other things that are contributing to that fall. Many of our referrals start off as fall risk or lift assist, but end up being so much more like the other items on this criteria. Next slide. So the referral process is mostly in-house. We've trained our shifters, which is our EMTs and firefighters going into the home, to identify all the things that were on the slide prior. And also just their gut feeling. If they go into a home, whether they transport or not, and they identify somebody needs a little bit of help, they refer that to me. It goes through me through our image trend, which is our report writer system, through an email. I approve it and I send it in to Consistent Care to their referral. It ends up going into phases, and then our resource navigator, Heather, pulls it down from there. One of the big things that we do with this is we have to have a release of information. We're teaching the crews right now to have that signed when they're on the call, when they respond to the 911 call, and that helps save time, because one of the, like with what Eric was saying about falls, sometimes we don't have the accurate information, or we don't have a phone number. So, or sometimes they're homeless, and it's really hard for our patient care advocate to go and find this person, because sometimes people, don't stay in the same place. And so that is one thing that we've really been trying to focus on with our crews, to have a release of information, so that way she can just start and get to work and not have to chase them down for that. Next slide. So this is the bubble that I was talking about. And this is just a handful, but we have all these resources. The fire department has a very, I shouldn't say fire department, I should say City of Pasco. We really didn't know how to navigate this ourselves. I can't imagine what a patient feels, or like how they don't understand how to navigate. They don't understand, when they get released, from the hospital, what their instructions are most of the time, or, it's very hard to navigate. And so by us hiring the resource navigator, she actually has, personal relationships with each and every one of these. I'm probably missing many, like Knights of Columbus, Eric mentioned. She's going there all the time, helping with wheelchairs and crutches. And the Sozo Food Bank, they've opened up their food bank when they're closed, so she can stop by and get food sources for people. It's amazing the partnerships that are happening here. I'm very, very excited to have all these community partners. I know I'm probably missing a few on here, but it's probably the most key factor in making our program successful, is the relationships we have with each and one of these agencies. Next slide. So our goal, like I said, it's not to have a referral and keep the patient open forever. What we want to do is go into the house, figure out what resources they need, and then to close the patient. And really, by doing that, it really has decreased our 911 calls. So a lot of times the patients, we help them out, they're stabilized, we close the case. Unfortunately, sometimes we don't get into their life until the very end of life, and so some of our referrals, they do pass away, and so they're closed that way as well. Every once in a while, we do have someone that just refuses our services. We try to, at that point, we try to educate them the proper use of using 911 system, but sometimes that doesn't matter, and they do still keep calling us. And we always leave it, if you change your mind, here's our card, feel free to reach out to us. And then we also use our paramedics to, educate as well when the people are adamantly refusing services. And that is their choice. We give them that right. Just sometimes you can't help everybody, I guess. Next slide. So here's some quick referral numbers. We started this program part-time late, I believe November of 2019. We had 8 enrollees. That year, 3 were active and 5 were closed. In 2020, our resource navigator went full-time. For the year, we had 58. And this year so far, we have 63 enrollees. We figured out kind of the average time for each case lasts about 3 months. That's kind of an average time. Some of them are very open and shut cases. Some cases are extremely difficult and might go longer than 3 months. Next slide. Here's some stats. As you can see, the middle, I call it the beach ball. You can see that age, we don't discriminate against age. We help all ages. I always kind of tend to look at the 50 to 60-year-old age because I feel like that's an age where we can help someone navigate resources to help them live into their 60s, 70s, and 80s successful. It's nice to go in and try to figure out, okay, what at this age has happened to get you to this point where you're calling 911. And I feel like that age is an age that we can really help fix the rest of their life. Going over to the left, referrals by gender. We do have, it looks like, you know, a little bit more male for our referrals. The unqualified, I'm going to talk about just briefly. Sometimes it's a patient that we can't find. We can't locate them. They might not be from this area. They already are living in a certified or a licensed facility, so we don't help them at that point because they already have full help. And that goes over to the right-hand side, the reason for disqualification. Sometimes we just can't find people. Like we try, she'll go out, she'll go to the location we picked them up, or we'll find out, we collaborate with Pasco police to find out if it's a patient that they know, like where they are located, and just sometimes we're unable to find people after referrals. Next slide. I guess that's it. Chief Dunbar, do you have any comments that you'd like to share? I know I went through the PowerPoint pretty fast.
I think the biggest thing with the program is it's been very successful and well received by all aspects of the city. It's one of our keys that we hang our hat on, that we're trying to address the issues and reduce the number of 911 calls before they happen. One of the examples was we had a certain individual who was calling literally every day, sometimes 2 a day for about 3 weeks. We got Heather involved through the program. Literally the next day, the 911 calls stopped and we hadn't heard from him until the very last 911 call about 4 or 5 months later when he finally passed away. So we're seeing that positive impact, and we're actually using this program to manage our growth. You know, Pasco's growing very rapidly. So of course our call volume has gone up 5 to 6% over the last couple of years. Many of those calls are these routine 911 calls that really don't belong under the 911 system. By getting this program put together and supported, that's how we're going to be able to manage that growth a little bit better. Get the resources to these people who need them so that they can have a better, healthier, more stable life. And it's just a way for us to have a positive impact and manage our growth as we move through the future.
Chief, quick question, Chief Dunbar. How are you quantifying cost savings to the city in terms of the 911 calls, that the repeat, what is the MVPs?
Not yet. That's one of the things that Ben and Michelle and I spend a lot of time talking about. That's one of the reasons we put the community health worker, our PRN person, Heather, on the radio, and we're tracking calls of where they're going. And then we compare addresses, those kind of things, to where we went to calls before, and see if this person would have kept calling, what would we save? You know, and every time we transport somebody, you're looking at $3,000 to $5,000 in our costs, let alone hospital time and those costs. So that's one of the performance metrics we're going to work on the rest of this year to try to identify. It's hard right now to quantitatively say it, but anecdotally and qualitatively, we are seeing a reduction in the 911 calls for those that we've been able to help.
Thank you, Chief. Any more questions of Michelle or Chief Dunbar? That's quite a story you've told.
Patrick,
So I hope there
actually,
would be questions.
I did. So could one of you address the Pasco Municipal Code? You had mentioned two different ordinances that you had passed, one that was a charge for non-transport and a charge for 9/11 abuse. I'm a little bit more interested in the charge for non-transport and whether or not the other cities across the Tri-Cities are also doing similar ordinances like this.
I'm not sure, Michelle, you might have a little bit better idea on that. I believe most of the cities do have that option in their municipal code. Go ahead, Michelle.
Yeah, for us, it's mostly used if we treat and release. For example, if we go to 911 call and it's a low blood sugar and we give D50 IV, and then the patient becomes alert and eats their peanut butter toast and decides, hey, I really don't want to go to the hospital. That was a way that we were able to bill for the medications that we used. A lot of times, if we just do a quick well check, we don't bill that. But when you have someone taking our ALS ambulance out of service because they want us to come out and check them out for a routine checkup, initially, that's not a charge, but it does become a charge when they start pulling over and over again, and they're actually taking, a paramedic, an EMT, and a fire engine out of service just because they want their vitals checked. We do try to educate. That's not, appropriate use of the 911 system because it is taking us out of service for someone else for a true emergency. And so we are able to charge $250 for an assessment, including vitals. And a lot of times it does discourage them from using us inappropriately, but not always.
Thank you, Michelle. And we're hopefully at the end of these presentations, we're hopefully going to ask our managed care organizations some questions about possible reimbursement for these types of services. So thank you very much.
And Carol, this is Bob. Just kind of a little history. Both of those are really hammers that we need to use once in a while with people that don't get it. And so it does give us a couple hammers to say, if you're not going to accept help, this is what it's going to cost you every time we show up here, or this is the ticket you're going to get for misuse of the 911 system. So it was just something we put in place to have a backup for non-compliant people.
Makes sense. Thank you, Chief Gear.
Any more questions? We've got 3 or 4 more minutes before we take our break. Any more questions of the Pasco Fire Department experts? Then let me use the prerogative of the chair to ask Michelle or one of you, what do you anticipate the ACH funded intern will be able to do for your program? That's an 18-month assignment. Do you see that person fitting in quickly with, I guess the person's name is Heather, and really giving you an expanded capability?
Yeah, absolutely. What we find is that Heather is spread so thin that she could probably put in 60 to 80 hours a week helping all the different referrals that we get. And by just beefing that up with that intern, we'll be able to address additional people and just address that growth where there's more work out there than Heather can get to by herself. And then also kind of getting a little deeper in and building those contacts and taking care of it. So that's one of the reasons we worked with Consistent Care to have them ask for the grant, and we're happy when it's approved. And instead of having one person that's almost overworked, that we'll be able to spread that around and build this program, because there is definitely a need out there that continues to be identified.
Great. Well, I'll just suggest to the staff that maybe after a year or a year and a half, we have another check-in with the Pasco Fire Department to see how this has panned out.
Absolutely. Thank you. Appreciate that.
All right. So at this point, I don't see any other hands up. We will take, let me just check. I don't think we've got any more hands up, do we, Demia?
No, we don't. Excuse me. And there's no comments or questions in the chat.
Yeah, you got some nice kudos, Michelle, for the presentation. So congratulations. I think everyone got quite a bit out of this. So we will then move on to Walla Walla's experience with this. But before we do that, we'll take a 10-minute break. Look forward to seeing everybody at 10:40. So enjoy the coffee or enjoy the sunshine.
Thank you.
Well, folks, we should probably get started now. This is Patrick Jones, your facilitator, because we would like to leave room for questions. And I'm sure we'll learn a lot from Walla Walla's experience. And to share that, we have Becky Betts from St. Mary's, Cody Maine from the Walla Walla Fire Department, and also from the Fire Department, Walla Walla Fire Department, Eric Woods, the Deputy Fire Chief. So I think I don't know exactly who's presenting. Is it Becky or is it going to be a tag team of all three of you?
It's going to be Becky for starters. I'm putting up her slide right now, Patrick.
Oh, there she is. Hi, Becky.
Good morning, everybody.
You have the floor, Becky.
Excellent. Thank you. All right. Thank you for inviting us from Walla Walla. I'm super happy to be here. And Sam, thank you for the invitation, and thank you, Laurel, for being the best practice transformation navigator there is. I had to give her a shout out. And really thank you to Greater Columbia for being the convener of movers and shakers and innovators and creative thinkers for our region. The gift of this leadership council. I always learn so much. As a leader of population health, I think about upstream efforts constantly. Where are the gaps? Where are the trends? What is happening with the health of our population? And aren't avoidable ED visits just another way of looking at upstream failures? Lack of access, knowledge, and mitigated and untreated mental health and substance use disorders, health inequities, and unmet social determinants of health. These things weigh heavily on my heart, and all of these issues cannot be remedied in an ED encounter. And really what weighs on my brain is that I'm responsible for looking at the data, lots and lots of data. I'm accountable to our value-based payers. I'm accountable to a healthcare system, CMS, and that I'm a good steward of resources that keep our doors open. So I have to take in that full picture of human trove and treasure, and I'm constantly on the lookout for collaboration and partnerships. That's my preference. I can't stand duplication and waste, and I feed off the energy of others. Next slide. For those that know me, I always throw a proverb in every slide deck for good measure. This is one of my favorites. Population health and community health is really heavy lifting. We all know that. I think we're fools if we do it in silos. And so if you want to go fast, go alone. If you want to go far, go together. Next slide. In January came a call for requests from our regional leadership board at Providence, seeking innovative ideas to decrease avoidable ED usage for mental health and or substance use disorders. After I read the RFP, it took about 45 seconds to call Peggy Needham. If anyone knows Peggy, you know she's a grand matchmaker. And then about 45 seconds after that to call Cody and get his buy-in and write up our proposal. So here's basically the description in a nutshell. We proposed that the community paramedic program would be a pilot program. We would serve citizens dealing with complex issues by assessing basically their needs in the field, coordinating their care in the field, and linking them to appropriate community resources in the field, really targeting those high utilizers of 911 and EMS services for non-emergent medical needs. And the program's benefit is twofold. Really benefiting, Providence and benefiting EMS and the city of Walla Walla. Citizens are connected to medical and social services that better meet their needs, and it creates a capacity for EMS and ED to really respond to genuine emergencies. The formal launch date was May 3rd, and the chosen one was Mr. Cody Maine. So we are just in the infancy. We are 6 weeks in, but I feel like we've already been doing this for a while. We do have some nuggets of learning to share with you. Next slide. I'm anxious to let Cody speak, so I'm going to move kind of fast and just pull out a few May wins. From a Providence perspective, Cody was able to divert eight ED diversions in May. That is a huge cost savings, not only to Providence, but EMS, our healthcare authority, and ultimately our tax dollars, right? Providence, a badge, he is a quasi-employee of Providence. Both badges, he bridges so well of those two environments. Next slide. And June, this is my last slide, but basically, you know, we're halfway through June, and the wins continued to be immense. It was in short order. We decided we needed 10 Codys. ED is not the place for non-injurious mental health crises. The environment's not conducive. It's not trauma-informed yet. And oftentimes patients in crisis are triggered and escalated in this chaos and stimulus of the ED. So one of my primary goals was to really work with comprehensive and work with different cycles that they could do that crisis response and triage outside of the ED. And so that was a big win to have them agree to partner with Cody, that when he responded to a non-emergent mental health crisis, that he could directly tap into the DCR and do that triage, not in the ED. Cody continues to build a strong relationship of all of Providence caregivers, but particularly the community health workers. They are the faces of Providence out in the field. We did get a BAA signed with our 2 agencies, which is the kind of the golden key to get Cody full access to our EMR Epic and Eddie. So that will be a key feature. Nothing moves fast in bureaucracy, so we're close to getting that for Cody. But with that will become the tap in for that dashboard and data that we can extract from Epic, which as soon as we get Cody's footprint in there, we'll be able to, you know, measure those ROIs on our end. And I think us presenting today is just a huge win, because anytime we can socialize and network and learn from each other, it is a win. So without further ado, it is really my pleasure to introduce you to one of the best humans I know, Mr. Cody Maine. Thank you.
Okay. All right. Oh, there we go. All right. So this is what I look like. I've been told I have a face for radio. Anyway, so I'm going to share my screen here real quick. All right. There we go. Can you guys see that PowerPoint?
Yes.
All right.
We can.
Make it a little bit bigger here for you. All right. So the Walla Fire Department Community Paramedic Program. Oh.
We see an Excel spreadsheet.
Yeah.
Oh,
Excel
man.
spreadsheet. PowerPoint was up there, then it disappeared.
Oh, I put it on the wrong screen.
I can pull it up if you need me to, Cody.
I don't know. Is it back now?
It
Yes,
is.
it's back.
All right, there we go. Cool. I'm not used to having 2 screens, you know. I mean, this is weird. Let's see. All right, so the Walla Community Paramedic Program, a short history. That's all I can provide because I've only been doing this 6 weeks. So anyways, we'll get going here. So it's a symbiotic relationship between Providence and let me see. It's a symbiotic relationship between Providence, St. Mary, and Walla Fire Department. So we'll do a quick biology lesson here. So symbiosis, right? It's comes from the Greek word of syn, together, and biosis, living together, right? So what is a symbiotic relationship? So there's 3 types. There's mutualism, right? It's a form of symbiosis in which both symbiotic partners benefit from the interaction, often resulting in a significant fitness gain for each other. Let's see. So both partners in this situation being Providence and the Walla Fire Department. Mostly what we see and the thing that we're trying to fix is the parasitic type relationship. The frequent ED user that you've heard about, the frequent fall patient, you know, the person who is really dependent on 911. So my hope is that we can take and we can change, with my belief, by forming a more, and I got to throw this out there. I put fortifying in here as a word, and I was like, man, that's great. Nobody else is going to use fortify. It made me feel smart. And then I saw Eric use fortified, and I was like, man, that didn't work for me. So anyways, by forming more and fortifying already existing mutualistic symbiotic relationships like St. Mary's Population Health and the Walla Fire Department, I believe that the parasitic relationships can be better managed and the lives can be improved for both the organizations that are involved and also, most importantly, the people who are dependent on those relationships. So what are we doing in Walla Walla? And one of the great things about both Chief Wood that you'll hear from and Becky is they've just given me free reign to be creative. You've seen a problem. I've been here 15 years in Walla Walla, and I've been in EMS nearly 20 years. And I've been in different organizations in different states, and a lot of places have the same problems. So the problems that we have in Walla Walla definitely aren't unique. You know, we have the falls just like Eric was talking about, and we have the same problems that they have in Pasco. But I'm allowed to deal with those issues the way that I want. So my guiding principle is, what would Grandpa Coker do? So my grandfather, he was one of the absolute most genuine, kind people. He lived in a small town. He planted a huge garden. He lived by himself. He didn't hardly use any of the produce that he gardened, and anybody that lived in and around that community was free to come to his garden and pick from there. So that's my guiding principle, is what would Grandpa Coker do? And if someone were to tell him, guess what your grandson did for this person, he'd be proud. So that's how I go about it. So daily goals: meaningfully impact people's lives. And they can be really simple things, I've come to find out. Show grace and respect to those in my care. One thing I heard through my own troubles and situations in life, and a good therapist told me, do not take anybody's dignity. They've probably already given it away. Simple solutions are generally the best solutions. And one of the other things I want to do is assist my coworkers in situations that can help reduce just the stress of work life. And a gentleman who is a community paramedic in Camino Island, I talked to him, and his daily objective is just do good. So the program goals, I want to show that community paramedicine is a unique and meaningful form of medicine, meeting people where they are, not necessarily physically. That's what we've always done as EMS, is we've gone to the location in our ambulance with all of our expensive tools and training and everything. But we typically don't meet people emotionally and genuinely, meaning that we have limited resources and limited time. So we've always tried to address that situation that the person called for as quickly and as efficiently and as compassionately as possible, but probably not always to really the level that the patient needed. So that's what I mean by emotionally and genuinely. Let's see, I want to relieve some of the burden from our engine companies and medic units, and also the emergency departments. I want to be an advocate for the patient while balancing the stewardship of emergency resources and services. I want people to make sure that they get the help that they need, but I want to make sure that they're getting the right resource. And the right resource isn't always a fully staffed engine company or advanced life support ambulance or a trip to the ER. So let's see, provide an appropriate and agile response than a more traditional EMS response. Have never really been able to provide. So one of the benefits that really wasn't foreseen, but I think is a really big deal of this position, is to act as a liaison between the Walla Walla Fire Department and other local social service agencies. I know as a provider out in the field, just kind of some of the key players and what they do in the community, but I didn't really know how to access them. I didn't really know all of their services and everything. So having somebody that knows, hey, if you're in this situation, call this person. It has been really beneficial, I think, and will continue to grow. Act as a pathway of information to Walla Walla Fire Department members regarding local trends and frequent utilizers. Getting into the charting system that Becky was talking about, I'm really excited as to how that can open up what I can do. I think I've kind of been maybe hobbled a little bit getting out and seeing people, because I don't want to go out and mistakenly trip up a potential patient because I don't know all of their history, or I don't know their care plan or anything. So having a fluid way, such as a access to the electronic health record, will be really important. So some recent outcomes, these kind of go back to the simple solutions. One gentleman, he calls frequently. He splits his time between our local homeless shelter and his mother's home, and his medications don't always make that transport with him. So one of the things that I did was I went to the call where he was. He didn't have his medication, and then I was able to go get his medication at the other location, bring it to him, and that was it. That was a simple solution to divert the use of a advanced life support ambulance and a trip to the emergency department, because he just needed his medications. Another lady who I've seen many times over the last 6 weeks, she called me personally on my work cell phone at 8:15 one morning and said her foot hurt because she got out of bed and tripped. And normally this lady would have called 911, talked to the dispatcher, tied up the dispatcher for a while, who would have dispatched an ambulance. This lady would have taken up that ambulance and gone to the emergency room and had an x-ray done to her foot that she didn't need. Instead, she called me. I went to her house, looked at her foot. She could walk. It was a little swollen. So I went to her freezer. I found a bag of peas, and I put a bag of peas on her foot. And that was a 30-minute visit with her, and she got some help that she needed. And we freed up resources. We diverted a call from the emergency department in a very simple way. Another gentleman here in town, he has been having some problems and with his job outlook, his employment, leading him to some suicidal thoughts. I was put in touch with him, got a hold of him, and he said, man, I'm just trying to scrape up some money to get to a job interview and a dental appointment. I said, okay, that's your big issue today. We can fix this, right? You'll be having a good day. And he goes, yep. I said, okay, sounds good. So I swung by my house and in my work vehicle, picked up my 5-gallon gas can and went to his house, put 5 gallons of gas in his rig. And also our union's benevolent association allowed me to buy him a $50 gas card. So I gave that to him as well. And he was able to get to his job interviews and his dental appointment. And it really changed his outlook. You know, that assistance provided an outlook that life is good, people care. I helped the same individual obtain a Washington driver's license to maintain their housing and ability to drive to interviews. And one of the things I learned in my trip to Bellingham with their community paramedics is just the loss of a driver's license, not through suspension or anything, but just it expired and a person doesn't have funds to replace that license. They no longer have a valid form of identification. So trying to get an apartment is difficult. Maintaining an apartment is difficult. One person in Bellingham didn't have a driver's license to renew their certification for their flagging job. So they lost their job. They no longer had a prevailing wage job because they didn't have enough money for their driver's license. So they were living out on the street. So some financial outcomes, the Walla Fire Department spends $1,338.09 every time one of our ambulances leaves the station on a response. That doesn't include any kind of transportation or medical care or anything like that. Just the base cost of an ambulance leaving is $1,338.09. So every time that I am able to take a call, I'm saving the department, you know, a good chunk of money. In May, when I started, I was on scene for 734 minutes, and that's time freed up from frontline units that can respond to more legitimate calls for service. Also, it allows those guys to catch up on reports, be able to attend training that they otherwise would have missed. June of this year so far, I've been on scene 951 minutes. So the impact to the hospital, the emergency department, is estimated that just walking in the door and having a doctor, an emergency room physician look at you costs $2,400. That's not including an IV or a 12 lead or an x-ray or anything. So I'm using that as my number for emergency department diversion, excuse me. In May, it was 8. So 8 ED diversions times 2,400 is $19,200 of savings. June of this year so far, 14 times 2,400 is 33,600. Put those together, I figure we've saved somewhere around $52,800 to the hospital. So the original grant that Providence provided to our department was $110,000. So I figure that there's about $57,200 yet to pay off of their loan, or I'm sorry, our loan, if you will, our grant. So that's 24 ED diversions. So that's going to be incredibly easy to make up here. And one of the things that I've said since this started was, in order to recuperate money in a healthcare system, we're not going to be counting pop cans. You know, we're not picking up 5 cents at a time. We're picking up thousands and thousands of dollars every time that we can point somebody in a more legitimate way.
Cody, is this your nice way to tell me that in a few weeks you're breaking up with me at this rate?
No. I intend for this to be a long-term relationship. So, the community paramedicine program, I feel, is only limited by imagination, and imagination is really only limited by funding. So that's what I got so far in the 6 weeks. That's my nuggets. I know Bellingham, they've seen this since 2014. They've been doing this program, and during my time up there, I was told by their shift personnel that their guys on shift, they do not like working Fridays, Saturdays, and Sundays because the community paramedics aren't out running calls and doing what they do. So guys appreciate what they do. It allows them to be more nimble in what they do, maintain training and everything. And it's proving to be a really good program so far. So I don't know if Chief Wood has some here to add to it.
Thanks for that presentation, Cody. And I just wanted to highlight a couple things. You know, as Cody mentioned, imagination is the only thing slowing us down or holding us back. But you know, I saw a couple comments. We need 10 more Codys, and that's just a fact. In 2014, when Bellingham started their program, they started with 1 community paramedic, and they're upwards of 4 people working variations, 410s, 12-hour shifts, you name it. But that's one of the areas that we're starting to see where we think we need to expand, and that's that 24-hour care and coverage. And obviously that can be looked at a bunch of different ways. But I know there was a question earlier, I believe it was for Captain Nielsen, you know, where we got the cost and a diversion for emergency medical service. And Cody pointed out that $1,300. We had a study performed a few years back, and it's a fee for service. And what we identified is how much it costs for our ambulance or units to run out the door. And that $1,300, yes, it's attributed directly to EMS, but our EMS units also serve as fire suppression activities. So I would probably say that number and that dollar amount is higher, and that's a savings really to our taxpayers when we can keep our units in service for those true 911 emergent incidents So I believe that dollar amount's actually higher. So that's a conservative approach, something we can back by factual data that yes, that $1,300, we know that is a cost savings to our citizens. So I only see that number growing. And I think along with Becky and Cody, we're always looking for innovative ways. And I think this is just going to flourish. And I think it will become a prominent thing that we will see in our community. And I'm excited to see where it goes. And we, again, thank you for the opportunity to present to you all. And I'm sure if you have questions, Cody, myself, or Becky are happy to answer.
Thank you, Chief Wood. I hope we do have questions. We're a little ahead of schedule, so anybody on the line would like to ask the representatives from Walla Walla about their experience so far, brief as it is, or perhaps post some comments.
Patrick, Suzanne has her hand raised in the chat.
All right. Thanks, Demia. Patrick, this is Suzanne Swadner again from the Healthcare Authority.
Yep.
This is Suzanne Swadner from the Healthcare Authority. I want to thank you, Greater Columbia, for having these really informative presentations and very energizing. Every one of you deserves a ton of praise for innovative thinking and really making that good commitment to the people you serve. I'm a nurse by background, and firefighters are among my favorite people I ever worked with because of how committed you are to the people. I'm wondering, I'd like to find out a little bit more about your programs and kind of the nuts and bolts of how they work and where your funding comes from. I have a colleague who's also working on understanding community paramedicine. Carol and all of you, what would be the best way for us to kind of just do a get to know you meeting so I understand a little bit about this, just so we can think about this in terms of how these direct service workers make an impact, and you're doing such a good job, it would be nice to snapshot your group. I'm also participating on a National Center for Medicaid Service, Medicare and Medicaid Services learning collaborative over the next 2 years about direct service workers, and I'm hoping to bring your role into that discussion. It often focuses on community health workers, and Cody's just a great example of the creative and innovative way we can use the community health worker function and the firefighter function to really spread our ability to serve people. And I'm hoping I can learn a little bit more about this so I can bring your success to a national audience.
So Carol, do you want to take a stab at that? And Suzanne, my suggestion would be you can do a wine tour and come down to the Tri-Cities and go to Walla Walla and enjoy a little bit of that and learn a lot. But I'm sure there might be a more efficient way.
Sign me up. Sign me up.
Well, who would resist a wine tour in Walla Walla? My goodness. Yeah, Suzanne, we'd love to chat with you. We can organize a time for all of us to get together and discuss, how we can better implement these programs across our state. And you can take that information to CMS and our managed care organizations. We're hoping to talk with them at the end of this meeting again about possible reimbursement, because that's really, I think, the key to keep these programs going that save so much money for the citizens and the healthcare system.
Suzanne, this is Becky, and from Walla Walla, and I brought 2 community health workers into my program last year, so they've been a year, and I have a file cabinet just full of stories that would spin your head. My most recent favorite is one of our patients who Cody and Eric are very familiar with, that just could not stay out of the ED. He was a 19-year-old who riddled with mental health, substance use, type 1 diabetes, clearly just not able to make it and live alone, and use the ED for sandwiches and soda and all sorts of things, and really, really expensive. And we could not, everything we did, everything we threw at him just would not stick. And our community health worker really recognized that this is a young man who needs supervised group living, and advocated to get him in a group home situation. And the MCO pushed back and didn't want to pay the daily rate of $130. And our community health worker, they wanted to pay $84 a daily rate. And our community health worker started doing all the math of all the ED utilization, the EMS, the inpatients, the hospitalizations, the detention, and went back at him and presented a pretty convincing case. Said, okay, it's costing you $1,892 per day to keep this young man living independently in Walla Walla. Do you want to pay the extra $47 a day in a group home? And so he's in a group home and hasn't had one and utilization sense. So I think that is a power of a community health worker who works and leverages a healing, authentic relationship, who brings a perspective to healthcare that we don't know because we're not in clients' homes and patients' homes and understanding them on a deeper level. But this is changing and transforming healthcare.
Yeah, this role in particular in connection with the fire department and the in and out of the paramedic is really fascinating. And I love that the community health workers are closely linked too, because it's about connections. So I'll look forward to learning more. And I think we can all acknowledge some of the complexities of our payment system and the rules and regulations that exist around them create some issues around finding creative ways to do this work. But I think one of the things we'd like to know is what are those looking like, because I can bring those kinds of questions up in my learning collaborative and we can kind of start a dialogue. And I need to hop off, and I want to thank all of you again and everyone who's done presentations. This has been an outstanding meeting. Thanks again for having me.
Just real quick, Suzanne, I can throw one thing at you when you said unique solutions. One of the things that they did in Bellingham that I thought was really good, really unique and everything is people who say have schizophrenia, right? They have to take a very unique or very complex routine of medications. So somebody who takes medications 5-6 times a day, you know, who already has a mental health disorder, that's really difficult. So one of the things that they started doing in Bellingham with medical directors and things are injectable antipsychotics. Right. So they'll give somebody, instead of somebody reminding or remembering to have to take their medications 4, 5, and 6 times, the community paramedic goes out and actually gives them their prescription injectable antipsychotic that lasts for a month. And they said that just the community paramedic doing that for a patient, spending 15 minutes, giving them their medication, cuts down on the one individual I was around with when we did it, when I was up there riding. They said if they didn't give her the medication, they'd probably see her between the hospital and the ambulance 20 to 50 times in a month. And that doesn't count into the equation how many police contacts this individual would have too. Right. So just that simple solution of making sure somebody is properly medicated all the time was a huge thing for Bellingham to do.
And beyond costs, it does what Cody said so well. It gives them dignity and gives them an opportunity to live a better life and achieve their own life goals. I will, when I meet with you all, I'll make sure that we talk a little bit about what other programs might exist, because I'd kind of like to put my finger on where those are, just so I know the kinds of things that are happening. And again, thank you so much for what you've done, and Carol and Damia and Chelsea and your team. Thank you for a really great meeting and having me there.
Thank you, Suzanne.
I'm gonna pop off now. Bye-bye now.
We have a question from Debbie Spink, and this I think is for all 3 fire departments, and it's namely this, if you see it in the chat box: what kind of training do you provide to the paramedics so they can function as a CHW? Anybody want to take a stab at that from the 3 fire departments?
So I'm doing it. I think it's just experience, really, out on the street and knowing your community and the trends in your community and everything. There's no real training to be a community paramedic. I have my standard operating procedures and guidelines and protocols and everything that our medical director allows me to do. It's just really taking that knowledge base, the experience I've gained through my career and knowing the community, and really kind of tying it all together and understanding that the best medicine isn't always come from a vial. You know, I think one of the things I've said is that, you know, sometimes the best medicine is conversation, compassion, a cup of coffee, and a warm pair of socks, and you can, you know, really take care of a lot of issues with just that. And that's just something that traditional EMS doesn't have the time to do, nor does the emergency department.
Okay. Yeah. Okay. So your community. Anybody else from Pasco or from Kennewick want to weigh in?
This is Ed Dunbar from Pasco. I agree with Cody. So there's the training is just awareness of what's out there and what the issues are. We're not necessarily training our medics to do the work. That's why we went to an outside organization and a community health worker who had that background, and to make those communications and that connection with the individuals, because that's really what's needed. Is it takes time, and that's the key, is to quickly identify who needs that, and then get that person who can spend the time and like Cody say, bring that clean pair of socks and the clean pair of underwear, and make the guy in a blanket, and make that individual feel safe and cared for, and just spend the time.
Okay, thank you, Chief.
Patrick, this is Diane.
Yeah.
I know that we have some of the MCOs on the line, and you know, maybe we could bring them into this discussion.
Yeah, no, that's part of the plan, Diane.
Okay, perfect.
We still got 15 minutes, so I just wanted to wrap up this follow-up to the Walla Walla experience to date. And
there's a question also from Debbie Speak in the chat, Patrick.
I'm not seeing anything new from Debbie. Oh, yeah, okay. You have another question, Debbie?
Excuse me, yes, I was just wondering if folks were aware of the DOH Community Health Worker Training Program. I know many community paramedicine programs have sent their paramedics through the training program just to get an awareness, an idea of what a community health worker does, and what their skill set would be. So it's a free program, and they have lots of other trainings that are also free. So just wondering if you guys had thought about that. I know that Chelan Douglas EMS department sent their entire every paramedic they had on staff through the training program, and really found a lot of value in it, because you know, that training program really talks about just what you're talking about. You know, it's really important to make that personal connection, even if that means just having a cup of coffee, you know, being aware of different cultures, being able to communicate with a lot of different folks, just kind of goes over that skill set. So just wondering if you guys were aware of it, or had sent any of your folks who are in your community paramedic programs through it.
Debbie, this is Becky. Of course, my community health workers have gone through it and loved it. And I just now, thank you for the idea. I'll extend the offer to Cody, because apparently he has me down. I only have him for 24 more avoidable ED uses.
I saw that.
I'm liking the day shift hours. I don't want to go back to waking up at night. I did that once in the last 6 weeks, and it was horrible.
Okay, and you've gotten some feedback, Debbie, as well, that this was a great idea. So thank you for bringing that up. And I would just ask people who would like to communicate a little further with Debbie on that, just to do that in the chat box. In the remaining 10 minutes or so we have in our Leadership Council meeting, I'd like to do what Diane was alluding to, which was to ask the MCOs who are on the line, and I don't know all of you who are here, but I would ask you not to be too bashful, and just if you wouldn't mind giving us your initial feedback to what you've heard from Pasco, what you've heard from Kennewick, what you've heard from Walla Walla, and how that might fit into any future plans that you may have to support this kind of work. So who wants to venture out first with his or her hand up from our managed care organizations?
This is Norma Owens. May I go first? Because I need to present in about 6 more minutes at another meeting. So may I go first?
Go ahead, Norma.
It's nice to see some familiar faces here. Really great presentations today. One of the things with our managed care organization, Coordinated Care Washington, our home office is in Tacoma. We have in the past had agreements, MOUs with entities like Eastside, Pierce County Fire Department. We've done some work with FD Cares out of Spokane in the past, and just echoing everything that everyone has said today. But it's not always easy to engage folks that are high utilizers or having any issues around BH or SUD. And it's not a one-time visit. At this point right now, we're not contracting with anyone. Our community health workers have been at the front line of working with COVID for the last, 16 months. But we do accept referrals from any of our providers in the community, which is not just a medical provider. It could be law enforcement. It can be from WIC. It could be from one of the fire departments. If one of our members is identified as being someone who needs additional help, we are certainly willing to go out. And we had switched to 100% telephonic during COVID, but we are slowly going back out in the community again. We have been involved off and on with hotspotters in Kennewick and done some work with Lourdes as well, and that has also been very successful. I think it is absolutely great work. And you're right, building that trust with people is just so important. And somebody made the comment earlier that when someone with a uniform appeared at somebody's home, that it instantly gave credibility and respect. And I really believe in that. And I think that there can be opportunities for community health workers to accompany law enforcement or someone from the fire department. So we are definitely open to exploring more options as we move over into the future. And just one more thing I wanted to add before I leave, and that is we really believe in community reinvestment. And we are, over the next 2 years, going to be doing community reinvestment, which means that we do have an RFP or application process that we are sending out. And if anybody is interested in funding a program and would like to apply, I can send the information to a contact here and have you disseminate it through your group, because we will be looking at applications from the middle of July until the middle of August for this year, and then going into next year as well. So again, if you'd like to send me the contact, I can send out the application to anyone, and we're open to all types of ideas throughout the state. And thank you for inviting us here today.
Thank you, Norma. That was very helpful. So you see a little note in the chat box from Diane that people who have questions about this, just send it to Sam Wardell. You can see that in your chat box, and she will forward it on to Norma and others, I hope. So speaking of, are there other managed care organizations that would like to weigh in on what you've heard?
Sure, this is Kat from Community Health Plan of Washington. I'm happy to chime in. I mean, a fantastic program, and I know it's been one of the programs that we have continued to hear feedback about and information. I remember an in-person meeting prior to COVID, getting a presentation around the community paramedicine programs, and just really hearing about all of the great work. I think something that Suzanne said really struck me, I think especially in the timing that we're in right now. But before I go there, I mean, I think we as Community Health Plan of Washington are always interested in considering how we can learn more and think about what, you know, investment strategies look like. I think also considering sort of how we partner with our providers who are in, we do have a number of sort of advanced alternative payment methodologies within the Greater Columbia area. And so thinking about sort of how and where that sort of fits within our partnerships with providers that we have as well. And then I think just considering the timing that we're in right now as a state, as we consider our renewal, well, the extension of the waiver and then the renewal of the waiver. And thinking about, again, going back to the intent of the waiver, was to really be a place to demonstrate success, to just demonstrate programs that really are viable to continue to sustain and grow. And so I think as we're considering how the state is thinking about those next steps and what it wants to continue forward, and expanding Medicaid benefits that could, you know, more aptly reimburse and really cover benefits such as community paramedicine and community health workers, I think that that's a really great opportunity. And again, I know Suzanne is not on the phone anymore, but just thinking about ways in which we can join ACHs to advocate for that with the state, because that is, I think, an opportunity to really think about even that much more of a sustainable model for how these programs might be able to continue into perpetuity.
Okay. That's some good thoughts, Kat, and I think we're all hoping that there will be an extension of the Medicaid Transformation Project, but that's to be determined, obviously, over the next couple of years. In the meantime, is there anything else from the folks representing MCOs that you would like to just weigh in on with the group, and in particular to the fire departments in Pasco, Kennewick, and Walla Walla about your possible thoughts on reimbursement?
Yeah, I'd like to chime in. This is Brian Lang with Molina, relatively new to Molina. Joined a few months ago as our Director of Community Engagement, and appreciate the conversation here. It's a really rich discussion and an area that we're very interested in finding ways to support. I will say that we're doing a lot of work right now on trying to address social determinants of health and equity with our members. And there are some limitations with what we can and cannot do with just working with our clinical providers. And so we have a team of folks within our care management department that are actively working with various EMS agencies across the state, doing some care coordination and referrals. I believe we have 7 different groups that we've been engaged with throughout Snohomish County and Pierce. And we'd be really interested in doing some of this work within the Greater Columbia region, where we can help get more upstream, identify these folks who are having these needs and frequently using 911, to get them engaged with our care management team, help them get connected with other services and referrals and so forth. So we do have a dedicated group that's working on this project, and I would love to help get connected with some of you here to further that work. So really appreciate what I heard today and what was shared.
So Brian, thank you for that, for those comments. Is there a way you can share your contact information with those on the line, that if they have an interest in pursuing something with Molina, they might be able to take the next step?
Absolutely. I'll drop that in the chat right now, and anyone can feel free to reach out to me.
Okay, great. We have time for one more comment or question. If there is somebody else, if there is another managed care organization represented, speak now or hold your peace. We'd rather have you speak, of course.
I just think a mayor group. Is anybody from a mayor group on?
Thank you, Brian. I guess not, Diane.
Okay.
But we can certainly, you or Sam might be able to reach out and maybe broker a conversation with our AmeriGroup representative and these 3 organizations.
Yeah, we can reach out to, we have a bi-monthly meeting with the MCOs, and so maybe we'll have a further discussion on this with them at one of these meetings in the next few months.
Yeah, that would be good. Okay, and Kat just mentioned, and I think this is appropriate to touch on before we end here, that we need to make sure that HCA is involved in these discussions as well, between EMS, fire departments, ACH, and the MCOs. So good point, Kat. All right, we have reached the end of our 2.5 hours. I hope it went by fast for you. It went by fast for me. I learned a heck of a lot, and I'm also inspired, and I hope you're a bit inspired by what you heard today. There is, as we typically have done over the last few years, a little vacation in July. So no need to check in the 3rd Thursday of the month in July, but we will be meeting again in August. And that agenda will be posted sometime soon. And I would just encourage all of you just to be good digital participants in our digital meeting age. And if you wouldn't mind giving us some feedback via that survey in the chat box before you sign out, we'd really appreciate it. So we can make these meetings, we hope, even better for you. And so with that, I think I'm going to ask Carol if she has any closing comments.
Really just thank you to all of our presenters today. It was great information sharing. It was wonderful to, at the end, tether it to MCO reimbursement, and having Suzanne with the Healthcare Authority, I think gives us an avenue to be able to bring these opportunities forward for any of our community health workers and our community paramedicine programs that are trying to make it to work. So thank you everybody for being here today.
All right, thank you, Carol, and till August, and happy Father's Day.
And don't forget to fill out the link about the meeting. So
yes, right.
The survey.
Thank you.
We'll see you in less than 60 days. Thank you for attending.
Thank you, Patrick.
Thank you.
Thank you, everyone.